Hello everyone, it's 3 o'clock. Welcome to the Simulation Q&A, the sequel. We actually had another one of these workshops at the beginning of August, and this is session number 2 for those of you who have missed it. My name is Jana Bitt, and I'm the Executive Director for the Oregon Center for Nursing, and welcome, and thank you very much for joining us today. This is going to be a pretty small crowd, I think. We've got some of our experts are starting to jump into the call right now. And we just wanted to bring everybody together today to talk a little bit about what has been your experience with using simulation in nursing education over the last summer. What are you planning for for the fall as it's coming up? And what specific questions do you have? Because we have several people that are really interested in doing some professional development around simulation over the next year for faculty in both RN and nursing assistant programs. So we want to use this session like we used the other session as an opportunity to get feedback from you about what are the questions that you have about simulation and how have you been able to implement it, and what can we do to make it, to be able to share that knowledge across all of our nursing programs in the state to really elevate all programs. So just a quick review for those of you who were not here last time. We had, this is what we know about simulation. And as we've talked about before, for those of you who don't know, we've been working with the Oregon State Board of Nursing. And back in the spring, when the pandemic hit, the State Board of Nursing asked the nursing programs to submit plans of how they're going to be able to deliver their curriculum and deliver their education, given the pandemic and given the restrictions about getting together and social distancing and cancellations of clinical placements. So one of the things that they did is we worked with them to take a look at all of those different plans. And one of the things that we realized, or it was shared with us, is that first of all, nursing programs across the state were using simulation before, and they really ramped it up after the pandemic hit, which is completely to be expected. But one thing that we also saw is there was no standardization. It seemed like every program was just kind of figuring it out on their own with Google searches, or just with the bare necessities of what they were already able to access. So since it was kind of all over the place, we were thinking that there might be some questions, and we do have some experts in the state that have been working with us, and we're hoping that we might be able to answer some of those questions. So one of the things that the State Board of Nursing has done is they've approved online didactic and an increased simulation has been approved through the winter term of 2020. So this opportunity to use more simulation, especially in the fall term and probably into the winter and the spring terms, that opportunity is going to be there for all nursing programs. So one of the things that the Center for Nursing did is we did this in conjunction with the State Board of Nursing, is we pulled together what we were calling the Simulation Study Task Force, because originally our plan was to do a big research project over this. But the more we started to put some of the puzzle pieces together, the more we started to realize that we didn't necessarily need a new study. But what we do need is the opinions from people like you, and the feedback from people like you, and people who have certification, and people who have, this has been part of their career, is being able to do this nursing education, simulated nursing education. We need to hear from them so that we can build this community across the state around simulation, and we can make sure that there are experts in every single nursing program and access to experts across the state from every single program to make sure that nursing students have the highest quality education. So on the call today, we've got a really small group. There's about 11 of you if I subtract myself and the OCN staff. But what we're hoping for is that this is an opportunity for you to ask questions. We want to get an idea about what are some of the situations that you're running into as you're trying to implement simulation, especially into the fall. What have you learned? What worked for you? What didn't work for you? And what would you like to know more about? So here's the fun thing. The community of experts is all you guys. Everybody on the call today, you are all experts in whatever you know. That's perfect. So we would love to hear from you. Ask your questions and also just give us some feedback about what's been happening with you. So we would love to hear from you, and we would love for you to all participate. So this is a very interactive session. If you thought that you were going to be able to sit back and not really participate, you could just listen and answer emails on the side. And that is not going to happen. I'm getting every one of your pictures up here so I can call you and call on you and make sure that you are participating. For those of you who don't have your camera on, no judgment, but I still see your name, so I'm going to call on you too. So in order to participate, we want you to type your question and or response in the chat box, and you should see a chat icon at the bottom of your screen, or you can go into the participants and you can raise your hand and we can call on you. Be sure to introduce yourself and your organization. A lot of you I know already. Looks like Nick Neal from OHSU got a haircut, which is awesome. Good for you, Nick. And if you, as part of this discussion, if you have any documents or resources that you want to share with the group, we are going to be pulling this all together and post this on the Oregon Center for Nursing. We've developed a simulation page on our website. So we want to be able to put some of these frequently asked questions on our website or resources for you all to access. So I'm noticing that Kelly, I'm hoping Kelly put that in the link. She did. So Kelly Illich is our operations manager, and she's going to be our producer today. Rick Allgaier is our research director, and he's here to make sure I don't say anything too stupid about the research that we do. And Kelly's also going to be putting some links in the chat to some of the resources that we've been talking about. Now, if you don't have any questions, we might be able to end this all early. I don't want to end this early because this is your opportunity. We've got a lot of great, smart people on the phone or on the call today that can be able to answer some of your questions. And so, Julie Fitzwater, thank you for kicking us off, has a question that she put in the chat that says, we are using more standardized patients and wondered what other programs are used to orient/rehearse. What's the time commitment for rehearsal, and what do you provide to SPs for preparation? Who would like to take that one on? Because I'm going to probably call on Michelle Colazzo first, and then I'm going to call on everybody else. So what do you think about that? What's the time commitment for rehearsals, and what do you provide for preparation? Okay. Go ahead, you're good.
Yes. Okay. Our team is growing and growing, and we now have 7 SPs who we regularly utilize, engage with. And we've implemented a system. It's a tier 1 and a tier 2 rehearsal. So what we do is this summer, we met together in a very small group so that we could be socially distanced. We met in person to do a tier 1 rehearsal with the SP and with the primary writer of the case so that we could all come to an understanding of how the patient should be portrayed. We then recorded, we ran our scenes in abbreviated formats and we recorded them, and we used Teams. We posted those recordings on Teams. And then, so say I was the primary writer, I would get all their feedback and make some adjustments, and we'd all come to have a shared mental model about how this was going to be. And then I would revise a little bit. And then a couple weeks later, what we did is we hosted online rehearsals as an entire team. So that was our tier 2 rehearsal. And because these scenarios were acute care scenarios, they took place in hospital settings, we used the scene recordings to run basically like a dress rehearsal. So we would start at the top of the hour and get everybody kind of oriented to what the schedule was going to be, and we would run it straight through without stopping to ask questions or clarify, just run it straight through with pre-brief, scene, debrief, scene, etc., and using our recordings for those scenes. And then we'd have a final wrap up at the end. So we did a combination of in-person and online. We also, our SPs we're working with 2 of them in particular who are kind of I would say they were more of in a kind of a leadership type role. Essentially, it's informal, but a leadership type role on the team, and they are hosting standardization sessions just with the SPs. So they're all getting together online on team to review the guides, review the portrayal based on the rehearsals, based on that tier 1 rehearsal, and they're coming together and then bringing some clarification questions back to me as the coordinator, to work with and then, answer for them. That's how we're doing it right now. We do that we did that right before the semester started. It was like end of July, beginning of August. So we did 3 cases per week for 2 weeks. And then, oh no, I take that back. It was maybe a 3-week process. So we did the tier 1 and tier 2. That's how we decided to. But that's how we're getting the best standardization so far. I mean, we're only 2 weeks in to implementing, but so far so good.
Yeah, I was going to ask you how you feel like it's been going so far.
Admittedly, it's a lot of coordination and communication, and the SP group themselves, they need to, they're part of our team. I mean, we just integrate them so fully into our team.
Yeah.
So they communicate closely, and we have weekly huddles as a team. In fact, I just left our weekly huddle to come here, and we're all, talking about what went well, what barriers were there. We're all, again, taking that opportunity to get on the same page. We record all those huddles so everybody can see it if they can't make it. Other ways we support our SPs would be to really clarify what we mean by, what we mean, for example, by anxiety or pain, or and really try to standardize that portrayal so that that our students are essentially getting the same experience every time. It's a lot of community. Does that help, Julie? Is that, yeah? Okay. I'm happy to chat more or exchange ideas too.
Yeah, and I'm really jealous of the way you've integrated the SPs into the program as a whole. It's really a great model. Thank you for that.
Is there, and Julie, do you think that there's a way for you to be able to do something like that too?
In the future, yes.
Well,
it's your growth, for sure. It's growth. I mean, we didn't start off this way. So yeah, anyway, thanks. Yeah, thanks for the time.
That's great. I want to get to Jessica Sandstrom from Warner Pacific. She said, I am trialing the simulation software from Laerdal, which seems to be going well. I'm curious about best practices for pre-brief, debrief, and how to make the scenarios as real of a patient interaction since we're using SimMan. Paula, do you want to start? You want to address that a little bit? And Jessica, we'll unmute your line too if you have any specific questions based on kind of your experience based on this. But Paula, can you kind of address, like, what are some of the best practices for debriefing and debriefing when you're using SimMan?
Okay.
You're good.
Well, as far as the pre-brief, which is really kind of the orientation to the simulated learning experience, is you need to make sure that your learners are oriented to SimMan, so they know where to look for a pulse and what a pulse feels like. They need to know how to tap the monitor to get the blood pressure. They need to have a chance to listen to heart and lung sounds, so they know what heart and lung sound, what a rhonchi is versus a crackle, because they're not exactly the same as they are on people. So orientation to the mannequin, and then orientation to the room. So let them know where their supplies are, and what they should do if they need something that is not set out for them, and have a plan for that. And usually the plan is they call in, somebody answers the phone and says, "This is the charge nurse, what do you need?" "Oh, I need a 4x4. And then someone brings it in, because what you don't want your learners to do is spend their valuable simulation time searching for things that they think they need instead of engaging in the scenario. So orientation to the mannequin in the room is critical. Typically we assign some background study for the students, similar to what they do when they go into clinical. They have to prep for their patient, so they prep for their simulated patient. They maybe read the history and physical, they look up the diagnosis, They know what meds the person's going to be on, so they do all that preparatory work. As you start to introduce the scenario, it typically begins with a handoff report. So a nurse going off shift or handing off to the learners, and a report, like a handoff, happens. And that's critical to make it realistic, organized, and appropriate for your level of learner. So, and then you also typically give them an opportunity to ask any questions. The other thing you want to do in the general orientation is what we call create a fiction contract. So, and that's really important when you're using mannequins, because the reality is the mannequin is not a real person. They do not have facial expressions. There's no nonverbal communication. So acknowledging that and talking about how to get around with that, or engage despite that, and inviting your learners to engage in what's called a fiction contract. And one thing that I do when I first start my first encounter with my learners is I have everyone go around the table and tell me what their favorite movie is. And that does a couple things. It's kind of a warm up. You get to know each other and, kind of laugh and have a good time. But then after everybody's talked about their favorite movie, I say, okay, so here's why this movie has stuck with you, is because you unknowingly engaged in a fiction contract. And the producers of the movie created it so you would do that. And there were parts of the movie that were not real, but you engaged in the contract. So the story became real to you and meaningful to you. And that's exactly what we're asking you to do in simulation. We're telling you a story. You're engaging in a story. You're a participant in the story. And we need you to engage in this fiction contract. Then you run your scenario. And you, like we just talked about, you usually want to rehearse it. So you have the glitches worked out. As you set up scenarios, you need to think about 3 different kinds of fidelity. So 3 different kinds of fidelity means as getting the situation as realistic as it can be. So the first is the physiological fidelity. So you want to make the mannequin's vital signs and symptoms that you're displaying as physiologically realistic as possible. Then you also want to create your scenario so you have environmental fidelity. So the surrounding room, the pumps, the equipment, just how things look as realistic as possible. And then finally, you want psychological fidelity. So that's you engaging as if this is a real story. So don't be silly. Don't crack jokes. You set the stage. You, the operator, set the stage for that psychological fidelity. And one thing that I think is really important for creating psychological fidelity is how you name the patients and name the providers. So don't call your patient with COPD, I'm a wheezy, because I'm a, like that, wheezy, that sets the stage for this is not serious. And what we are doing is something serious. Don't call your surgeon Dr. Cutter. So make names that are just neutral and not silly. And then sometimes the learners will, they have a hard time engaging as if it were a real story. And it's really important that you, as the operator, the voice of the patient, or maybe you have somebody playing the role of spouse or somebody at the bedside, make sure everybody stays in character and bring the learners back in if they start to drift into, oh, this isn't a real thing. And as long as you take it seriously, they will follow suit. Then after the scenario is over, then debriefing. I typically choose some kind of debriefing sketch model. And there's a lot of them out there. I think many of us are using Pearls, and we can give you some resources for that. And I tend to scratch out a few debriefing questions ahead of time so that I have them in my back pocket. And I conduct my debriefing according to the objectives of my scenario. So that's another really critical piece, is keeping those objectives front and center, so that if the objectives weren't met during the scenario, you're assured to address them during the debriefing. Any other questions? Any clarifications from what I said? And my colleagues,
yeah.
to add?
Jessica, that was kind of like an overview of everything. Do you feel like that kind of matches with some of the stuff that you've got from Laerdal?
Yeah, no, that's super helpful, because they give you an outline of all of those things and kind of guide you. But I felt like it feels like the debrief questions weren't what I wanted them to be, I guess. So I think it'd be helpful to have a different tool to check. You know, just there's certain questions that I wanted to ask that weren't on the debrief, and I wasn't sure. I know they were kind of supposed to follow the script, so I didn't want to.
Yeah. So the Laerdal debriefing stuff is pretty, well, it's not necessarily nursing focused, for one thing.
Yeah.
It's very sort of generic, and it's more, my recollection, I haven't seen it for a while, but the questions tend to be more sort of related to tasks as opposed to clinical reasoning and thinking. And so, yeah, creating it, you know, hopefully you'll have a chance to maybe look at these articles, and I think there's some courses coming up that will help with debriefing. I personally think debriefing is the most challenging part of conducting simulation.
You know, this is Doris Rink, and Paula, one thing I was thinking is like the length of time that you run the scenarios. So, you know, like when we do simulations, everyone kind of knows that the scenarios run, you know, probably no longer than like 15 minutes, because I think it's important that you don't just that they don't continue on and on, so that you have a framework for, you know, that the scenarios are going to run about 15 minutes. And so they kind of can have a sort of time frame for what they're doing.
Yeah, I agree, Doris. So I think most people are doing 15, 20-minute scenarios.
Yeah.
Twice as long for the debriefing. And, you know, usually pre-briefing is 5 to 10 minutes. The literature is showing that pre-briefing is really important, and there's a bigger emphasis on pre-briefing than there was, say, 5-10 years ago.
And at PCC, we actually spend sometimes, you know, 20 minutes actually sort of talking, so the student learners can actually have a chance to kind of think about what about this kind of a patient, or, you know, depending on who the patient is, so they can kind of get to know the patient and think about, what are the priorities for this kind of a patient? So they kind of go in with some sort of like, okay, you know, I kind of have a plan. That seems to be helpful for the students to kind of like have a chance to think through sort of what they're actually going to do, instead of going in there and not really have had that chance to sort of come up with a plan. Just like when you're getting ready for clinical, you kind of thought about the patient and what are the things you think you're going to do for the patient. And it may change when they get in there, but I think it's good to have sort of an idea going in.
Excellent, thank you. Doris, you also had a question earlier that going back to the standardized patients, you said something about, you know, how do you recruit?
Because I wasn't sure, the person who was speaking, I didn't know where she works.
So Michelle Colazzo is from the University of Portland.
Oh, okay. So do you pay, you know, how did you recruit them? What was the interview process? Do they get paid? That whole sort of, before you get to the point of having standardized patients, how you get them to be through that process, because it seems like that's a very significant component to make sure you have the right fit of standardized patients.
Oh yeah, Doris, definitely. It's a big component, and we've gone about it several different ways. But what I would say that is a common theme that keeps coming up for us is that we do ask our standardized patients who they think would be a good fit too. They have lots of connections in their community. And so we've hired many of our standardized patients in that way. We do at our school, our SPs are employees. And so they do get hired at UP as an employee. And so they're not contracted, they are actual employees. We pay them hourly and we do interview them. We conducted interviews on Teams, or no, Zoom. I think it was Zoom this summer. And we just hired someone else, and we came across her through one of our current SP's recommendation. And then just spent an hour with her on Zoom and really just felt like she was a great fit. So we also started talking with our theater department about doing some collaboration work with them and their students. And so I think we're trying to look at other outside of the box types of methods to build our team so that we can really grow a very diverse team of SPs. That's the goal.
Very good.
So, yeah.
Excellent. Thank you. Thanks for that clarification. I also want to go back to Lynn Barton from Oregon Coast Community College, who said it's a new process for us. I just used a few this summer. We only did an overview of the process, situation, diagnosis, and how to best communicate with the students. Lynn, if you wouldn't mind, can we unmute your line and kind of give me an idea, like, how did that go for you? Was that something that was easy for you to kind of adapt to, since this was such a new process for you, or what were some of the challenges that you experienced?
Well, we did it before with students, a few terms where we did cue cards with our students and set them up and they were the standardized patients, but it's hard when the standardized patient is your classmate.
Yeah.
And so this summer I had a very small nursing assistant course, so went ahead and found employees on campus because of the distancing needed. I used people who are already on site and provided them background of what they were doing, what their role was, the diagnosis, if they had any specific needs because they were in a rehab setting, and then gave them a cue card and made sure that they stayed within the persona, and then facilitated that during our activities. But we only used them probably an hour and a half to 2 hours total every day, but we did a pre-brief, debrief, and then activities with mannequins around that as well.
That's great. Yeah, I noticed that Paula actually put in the chat. The other thing we do with SPs is hook them up with an earbud connected to a walkie-talkie. We then can coach them in the moment so they respond to students' unanticipated actions and reactions. It's hard when the SPs are other students, and even more difficult for learners when the SP is their faculty. So Lynn, have you been able to recruit people from that are not their peers and not their faculty? Were you able to do some of that this summer as well?
Yeah, it was, they were staff on campus. So the students, were only on campus this summer. So they don't see them all year like some of our other students do. They were completely foreign to the students. They didn't know who they were. I had some faculty that were off contract for the summer but lived nearby. So we had to be really mindful of all of the social distancing. And so that was probably the most difficult part, is making sure that the students and the SPs weren't together for long periods of time, that we maintained social distancing,
right,
and all of the other steps necessary. So yeah, it was great. The students had no idea who their patients were.
Okay, great, thank you. I want to come back to that in just a minute, but I also want to go back to Lisa Rye from Mount Hood Community College. She said, we have not been anywhere that proactive, and this is when Michelle was speaking, in our process, and I wonder if I want to make it more structured as we were training nursing assistants. Things not being standard is kind of more common. Lisa, if you wouldn't mind, can you unmute your line and kind of, when it comes to simulation in these nursing assistant programs, and we're going to have a whole other session specifically for nursing assistant programs next week, but this is actually really helpful that you're here right now so that we can make sure that we're asking the right questions next week and kind of inspiring the right conversation. But what's more typical for you when it comes to simulation and what you've done before in trying to educate your students?
Sure. Well,
definitely have not put as much work into it as I think that I probably need to now. Looking at all these things, but beside that, we generally just say this is the person you're taking care of, and these are the things that are going on. And we haven't used any designated patients. Essentially, we've had the students kind of doing it with each other, which I think has an advantage in nursing assistant training just in general, because it gives them an idea what it feels like to have these things done to you. You know, we've tried to do that in general before, but putting the scenarios in there and then kind of letting them change as they would, you know, just if the person doesn't answer or doesn't something, you know, to kind of keep it more flexible.
Right.
Which I guess kind of been good and bad, but having it more formalized would be good. We just usually say, this is the person and you need to get them ready for going here, or take them here and do this, or whatever it might be. That kind of, you know, just general skills.
So Lisa, have you had the experience of, especially because of COVID, have you had the experience where you've had students in a clinical setting that had to be removed from that setting because of a positive test in the facility?
We've had stumbles. We haven't had to be exactly removed, but like when we went to clinicals, they had a staff member test positive, so they couldn't have any extra people for 2 weeks. So that, you know, just what we've come into is it just throws all of our timelines out the window, you know. So what we thought the schedule was, it's not really going to be quite that way. But I don't feel comfortable, and you know, we've agreed as a program that we're not going to have nursing assistants just do skills on mannequins or each other. That's not, there's no way I feel comfortable that adequately prepares them to go to work. For the state test, but we don't want to just do that. We'd like them to actually, you know, be qualified workers too.
Yeah, that makes a lot of sense. Nick Neal actually put something in the chat called the Association of Standardized Patient Educators Standards of Best Practice. Nick, can you share what that is really quickly, just so I know what that is in context of what we're talking about? Unmute your line, Nick. There he goes.
There we go. Yes, so ASPE is a really great organization for standardized patient educators. And so the best practices, there's a lot there for the best practices. You know, it's pretty detailed, but it does at least provide some idea of, you know, the things to anticipate as far as training and development and prep. I think I have another article on scripting of standardized patients and some best practices around that I can take a look at as well.
That'd be great. Well, and I've got up on the screen this is our page that's on our website right now about simulation resources, and we are curating this from all of these conversations that we're having with the groups like you, with our simulation, we're calling them a think tank now, our simulation think tank, and with some of the things that we've been doing with our every Friday, we have the Oregon Center for Nursing Friday Huddle, and if anything comes up there, we also add that here. So thank you, Nick. We'll make sure that we get to that. So I'm going to go back to Lisa for just 1 second, because you said something at the very end about how you had the commitment as a program that you didn't want them to just, you don't want your students to only do skills labs and experiments on and practice skills on each other or practice skills on mannequins. You really want them to be able to get into the clinical setting, which makes a lot of sense. But let me ask you, are you concerned, or are you planning for when those placements are curtailed and you're not able to get your students in at the level that you want to? What's your discussion there? Is it more of a, well, we'll just delay them completing the program until we can get them into a clinical situation? Or have you talked more about getting like something like this, like getting a more structured simulation education as part of their program?
And we do use some of the simulations. We just have done it more as like a hybrid. So like, you know, when things first closed down and we were locked out of everywhere, and we had students who had been in a clinical setting for like about a week and a half or so, you know, so they were most of the way done. So we use simulation to finish their time. We can totally, and I think I feel comfortable if like half of the time that they're doing clinical, we're in a lab setting the simulation. We just don't feel comfortable with like that's all.
Yeah.
So yes, our plan is kind of to try to find something and get them for at least some. But if things, close up for whatever reason, then we're trying to be flexible in how to get that fixed. So.
Yeah, thank you, Lisa. That's actually, I love the idea of like, we're just trying to be flexible. I feel like that needs to be the motto of 2020, right? Let's just try to be flexible, people.
I guess the trick is I'm 100% willing to be flexible, but getting the same amount of flexibility from like the students has been a little bit of a challenge, just.
I can imagine. I can imagine. And probably some faculty that have been, doing the same thing over and over again. They're so comfortable with it. Now you're like, yeah, no, we're not doing it this way.
Definitely. Yeah.
Yeah.
We'll understand that I don't know the answer yet. That would be really nice. Because
yeah, exactly.
I don't know. We're going to figure it out. What about you? Oh, no.
And that's the other motto. 2020, I don't know. We're going to figure it out.
Yeah.
Very good. Thank you very much. So we haven't heard from Sandy Kellogg, and she's on the call too from Chemeketa, which I don't know if she's turning around so she can turn off her camera, but no, there she's unmuted. Sandy, can you tell me a little bit about what did simulation look like for you after COVID? And is there anything that you found particularly challenging as you have tried to adjust to the new normal?
The new normal is we're using more virtual simulations.
Okay.
So we used a product this spring, and I can't even remember the name of the product, and faculty coming back for thinking about fall decided not to use the same product. So instead they did a very lengthy review of ATI's vSim. Okay. And decided to bring that on board, thinking more like a broad picture, long term, like not just for a quarter, but what's this going to mean for an extended period of time. So the reason why they brought in the vSim product was because they could do that there's a 2-year package. They could see that really working out for the long term of first-year students and then moving to second-year students, whereas what we had before was, oh, nope, they're done. They've covered it all. Yeah. In one quarter, they covered pretty much the gamut of everything they could do. Okay. We did, for spring quarter, we stopped everything physically in our lab, so no more lab activities or simulation with SimMan activities. But this fall, we've been approved to go ahead and continue our lab activities and the simulation activities with our SimMan, keeping it an 8-to-1 ratio, 8 students, 1 instructor thought process. We have enough space that we can do that and get them in comfortably, well spaced, and still be able to kind of continue on pretty much status quo of what we've done before. We're not bringing students in to the lab setting / simulation setting just for what we would normally have brought them in, which was just about anything and everything. We've really boiled it down to these are the important skills that we want to have face-to-face contact with those students, performing those skills and running those simulations.
And Sandy, can I interrupt? What are those skills that you don't think that you can do through like a virtual simulation or any other kind of?
They want to see them do a full assessment. Okay. So bringing them in for an assessment, and then the IV skills, starting IVs, medications with IVs. They're doing some chest tubes, more of the advanced skills, I think, than the earlier, like first-year skills. And that's probably the difference, is they've really looked at what were the ones that we don't feel safe letting students just do virtually with the vSim product or recording on their computer. So that's what we're going to be doing with the rest of those type of skills. Is we set them up. We're sending them home with a really nice nursing bag full of all the paraphernalia they'll need to do these skills at home. And then we're setting them up with recording these activities at home with their family members and then submitting those videos for us to review. We've never hired people to do simulation. We have a nice standardized patients that go throughout the whole gamut of the program, first and second year, that they follow all the way through in their SimMan type scenarios. And so those will remain as they are already.
Okay.
Yep.
So assessment, IV skills, and chest tubes.
Just
so I'm
a couple of other ones. I don't have the list right in front of me, but
that's okay.
The more critical skills.
Yeah, but I'm curious. I kind of want to hear from Paula and Michelle and Nick and get an idea. Is there technology that's coming out that is showing that you don't necessarily, that there might be another way to be able to conduct those skills without it being in person? Or is it pretty much those are still the skills that you need to be doing at least in a lab?
So we're this summer with our summer ACVACs, we've approached it pretty much the same way Sandy described. So they're doing as much as they possibly can online, but there's some things you have to do a live demonstration, and physical assessment is one of them. So they might practice using virtual resources, but as far as checking off to make sure they're competent, that's happening live in the lab using social distancing and masks. So, and I mean, there's some things it has to be done with a real person.
Yeah. That makes sense.
I want to add, and the rest of you, I'm hoping that you can chime in on this knowledge, but I've been looking at other simulation products, virtual simulation products as well. And one of the things I'm really interested in, and not this year, it's too late this year to make this decision, but I want my faculty to trial it and then make that decision if we're going to incorporate it maybe the following year, is something like the Oxford Medical Simulation or UBSim. Have you all heard of those? What are your thoughts? I'm kind of excited about it. Jana, do you know what it is? Have you heard about that yet?
Paula is your person. So Paula, what do you know about that one?
So I didn't hear, the first one was what? I heard Oxford.
Oxford Medical Simulation.
Yeah, what was the other one?
UBSim.
I don't know UBSim, and maybe Nick does, but I know Oxford, and I agree. I'm pretty impressed with that. Our graduate programs used it in the spring, and it worked pretty well. Again, I think we're transforming nursing education because we have to, and we're probably all going to use virtual simulation products. And the change has been accelerated because of COVID. And even when COVID's over, we'll probably continue it at some level, but we'll also be back together in some way too.
Well, and I think
So, Nick, are you familiar with the other one, UB?
No, I'm not as familiar with UBSim, but yeah, from what I've seen with OMS and some trials I've done in working with the vendor just to look at the product, it's impressive in it's a very dynamic simulation platform, and it's not scripted, A to B to C. If you do an intervention, you see the changes. If you are late with an intervention, you see those changes. So there's a lot of good built-in I guess artificial intelligence around prioritization and clinical judgment, and it's scalable of using it on your computer as a screen-based simulation, or wearing something like an Oculus for VR, and it does have the capability to do interprofessional simulation as well, where the sort of virtual avatars are interacting and working on the same patient or with the same patient in real time. So there's it's a really dynamic platform.
Great, thank you. Doris, you unmuted your line. Did you have something you wanted to add?
Yes. We're trying to figure out, because PCC is one of the only schools in the state that's actually going to be totally remote so far and Laerdal has come out with this product. It's called Module Skills Trainer, and it actually is a way that it has the ability it provides a variety of different skills. Like you can put in indwelling catheters, you can do trach care, you can give injections, you can put in NG tubes, you could give oral medications, you can do stoma dressings, you can do wound dressings. So it provides a variety of different skill options for students to practice. It provides I call it a body in a box, but it provides that option, but the school has to provide like the straight cath kit, or if you're going to do a trach care, you have to have the tracheostomy, you have to have the dressings, you have to have the suction catheter. So it provides you one way, and you can actually then have the students test on a Zoom room, having them on Zoom and then going in and testing, do a performance evaluation, doing the skill, and having the faculty observe using a a validated criteria sheet. Yeah. So that's for some of the skills, that is something that we're, going to actually, try. And ATI does have health assess video modules for students to learn about doing different health assessments, and they go through it, and it does have some avatars, and we think that we're going to work with that for the first year students for first term for health assessment, because it seems like a pretty good product, because I've had to go through and do a lot of the different scenarios myself. And it does seem, because it provides the sort of the didactic and the practical at the same time. It's, I think it's different than the ATI skills modules. So those are some thoughts that we're kind of just, trialing to see how that works through this time of really not being able to be on campus.
Yeah, I'm hoping that we can get your administration to make an exception for the nursing program, but it sounds like it will only be for the clinical component. Yeah, but only for the clinical component. Yeah. Yeah. So the clinical skills lab will still be remote. Okay, so that's going to be. But I'm quite curious to see, does this provide an opportunity for students to actually practice those skills? Yeah. With different, ATI in the spring, I'm not sure if, Sandy, we used ATI real life scenarios, which are not avatar based, which are patient based. There's mental health, med surg, and OB and peds. So we were able to use those for virtual sims for the students. And those did seem to work pretty well. The students said they felt like it gave them a lot more chance to think about clinical judgment and what their interventions would be. So it was a different learning, but it did work for the spring. That's good. So if people need to augment their clinicals.
I think the other thing that we heard from faculty regarding using virtual sims is it allowed them to see when the students' clinical reasoning and clinical judgment was faulty in new ways that they hadn't been able to assess before. Mm-hmm.
That's good. All right, thank you. Thanks, Doris. And Jessica and Michelle have been having a little conversation over here on the chat. Do you guys feel like Jessica, did you get your question answered? Okay, so you feel pretty good about that? Great. So we have about 10 minutes before the top of the hour. Is there anything else that you guys want to make sure that we discuss as a group today? Or how about this? What do you need from here? Like what would be helpful to you now after we've had this discussion? It looks like Kelly has already added the article that Nick posted in the chat to our resources page. So that's already live if you want to take a look at that. But what would you need right now, and what do you think would be helpful for not only for yourself but also your program as we move into fall and winter, knowing that we have that COVID is here with us for a while, and this is really, like Paula said, accelerating nursing education innovation faster than we probably are comfortable with, but we're doing it. What can we do? What do you need now in order to be successful with your simulation work in the future? And Doris, your line is already unmuted, so you need to start.
Well, it will be interesting to see as like the term goes by, you know, how much people are being able to go back on campus. Well, how much are they really going back on campus? You know, what are the actual numbers? Is it, you know, how much are they actually able to do sim? What's the actual data?
Yeah.
You know, that, oh, we use this. Well, what are the numbers?
Mm-hmm.
How does that go within the OSBN? You know, is it, you know, we spent 40 hours in lab, and well, this term we only spent 10. So, and what skills did they have to do that they felt like had to be were the most important or the essential? The same with simulation. Mm-hmm. How did they decide what simulations they were going to do? I think some of that to help us sort of figure out what are the essential components and what can be done in different formats.
Mm-hmm.
And good. I'm happy to share what we do with the modular skills trainer, how that works out, because next week I'm going on campus to figure out what supplies we have to order for those.
Yeah.
So I'm happy to share how that works out at a later time.
Yeah, I think that there's a lot of people that would be really interested to see how that goes.
I know.
Yeah.
I agree.
One thing that Paula said earlier is that, you know, the clinical reasoning and being able to look at clinical reasoning through simulation and being able to try to get a sense of that. Are you guys also looking at that, like how, now that you're implementing these new products and these new simulation, and especially virtual simulation, how you're able to identify your students' ability to do clinical reasoning right away? Sandy, you had your hand up.
The reason why I have my hand up is because I think that is what it boils down to at this point. When we're using these virtual simulations, it's not to see if they can do the skill. You can't do that. It is all about clinical reasoning. What are they do? What's the scenario in front of them? What choices are they making? Are they going down the right rabbit hole or the wrong rabbit hole?
Right.
So it's not about the skill now. It's how they're interacting with that simulated patient, and if they're going to the correct next step. And I think in a way we can see that better with virtual simulation, like you said before, because, you know, on the floor, you're hoping they're going down the right rabbit hole. You're not able to watch them, you know, 100% of the time to know that they're making those correct decisions always. Mm-hmm. But in this way we can, because we can set the goals for the simulation. We can see if they've met those goals. We can go back through and watch the scenarios or see where they've made those correct decisions. And so I think in a way it may be a better product for us, but we won't know. I think everybody can agree we aren't going to know until we graduate the next cohort and then make adjustments and then make the decisions based on that information of what we're going to do the following year.
Yeah, exactly.
It will be a very interesting dissertation topic for sure.
Well, I was going to ask, I'm going to make an assumption here that OHSU is sending out surveys to their students to kind of get a sense of how they are reacting to this. Anybody else, Linfield, UP, Chemeketa, PCC, do you know are you guys doing some kind of student surveys related to simulation and virtual simulation? Michelle is nodding yes. Julie is chewing on her lip and now nodding yes. That's good.
There were two things that I think that students got an overall survey about having to be online with their education versus just the simulation part. So I don't think that has been pulled out.
Okay. Interesting. Great. Jessica, what about you? And do you know if they're doing any kind of surveying of your students related to the shift to online and or virtual simulation?
I'm sure that they are. I am.
You don't know.
Yeah, I don't know. This is my first semester in the role, so I've kind of just dove into the lab and created an entirely new lab scenario, and I've been. It's very clear the lack of clinical time is affecting the students' confidence and ability to even go through the scenarios. So I've kind of just dove in head first into scheduling as much open lab times with 8 or less students at a time. Yeah. But I bet Linda and Kathleen, our dean and assistant, they probably know about that.
Okay, that's totally fine.
Yeah.
Well, and also keep in mind that this whole group of people, we're here to support you. So congratulations in your new role, and you're not in it alone. There's a lot of people that you don't have to come up with all the scenarios on your own. We've learned that there's a lot of options that are online, and some things that really, really work in Oregon too, that we can hook you up with.
Yeah, that actually brings up another question, because the Laerdal simulations, they actually seem to be really good, but I would have to pay for them. And I'm wondering if you think that that's worth it, or if there's enough online free scenarios where I wouldn't need to do that.
What do you guys think? Is it worth paying Laerdal? Do they need more money?
I don't think so, but.
No, I wouldn't pay for them. So I think a place to start is actually the NLN has great scenarios online, and they have all kinds of supplemental learning activities that go with them. The scenarios are well written. They're appropriate for almost every curriculum, and they have some for older adults. They have some for veterans. They've got a PEDS module, or a group of PEDS. Anybody remember what else they have? I think that's it, but there's dozens of them, and they pretty much step you through how to use them. Mm-hmm. And some of them even have monologues, so the students can go on and listen to the patient's scenario from an actor who's telling them about themselves. Mm-hmm. And they're free. You don't have to even belong to NLN to get them.
We are big fans of free around here. So yes, that's great. Thank you very much. Okay, so I'm going to wrap this up because we've got just a couple more minutes, and I want to make sure that we get to everything. So what's next? What can you expect next? Well, the frequently asked questions based on today's discussion, it's not going to look like a frequently asked questions. It's basically what Kelly has been doing, which is we're taking some of these links and this discussion, and we're adding that to that simulations page on our website. If you want to know where it is, you can just go to the programs under OCN, and it's one of the options there. And you can see all of the simulation resources that we have been curating as part of all these conversations. If you are part of a nursing assistant program, and I see that we lost her. If you're part of a nursing assistant program, we are going to, I've asked Paula if she could give a presentation about the basics of a simulation, of trying to ramp up your simulation in a nursing assistant program. And then there's also going to be a Q&A as part of that. So please, if you have a program there, if you have any of your faculty, or if you know of anybody, you can take a look and go ahead and register for that. And then finally, we are putting together what we're calling faculty simulation training workshops. So this is going to be one of the goals that we have, is that in the state of Oregon, at least every single nursing program at bare minimum has one certified faculty who is certified in simulation education. So we're going to be starting to launch some simulation training workshops probably in October. We'll get some more details once we've got that all wrapped up. But if you are interested in that, we are hoping to use some grant funds in order to launch that, so that we can at least pay for one person from every nursing program to get some simulation training and some professional development around simulation, so we can have someone certified at each program. And with that, that's what you can expect. Any questions? Was this helpful? Jessica waved, so I'm going to say that's a yes. Was this helpful? Sandy says yes. Jane's only got her raccoon on. Lynn gives me a thumbs up. Michelle's got the great smile that I see all the time. Great. Thank you, Lisa. Yes.
Doris says yes.
Doris says yes. I didn't hear from Doris. And Julie is also smiling with her carpet that she put over her window. That is a window back there so that it's not so bright in her room. Okay, I'm glad this was helpful. We're not going to schedule another one right away, but if you guys feel like you want to get everybody together, just send me an email and maybe we'll do something maybe next month or as we kind of go through just to check in and see how you're doing and how your students are doing. If you have any problems as you are going into fall term and fall semester, if you have any questions or you want some other answers, send us an email because we can connect you to everyone here to make sure that all nursing students get just fantastic education despite the pandemic. So with that, I'm going to close it up. Thanks, everybody. Have a wonderful Wednesday, and we will see you all soon.
Bye.
Bye.